Hi, I'm Dr. Chris Lewis. I'm one of the chief educators here at Doctors in Training. Today we need to put down the bacon cheeseburgers and we need to pick up the celery. Today we're talking about anti-hyperlipidemia drugs. So let's get started. Let's talk about a general overview of hyperlipidemia. So coronary heart disease, or CHD, is the leading cause of death in both genders in the United States. CHD is correlated with elevated levels of low-density lipoproteins, or LDL. Now, the reduction of LDL has been shown to decrease CHD events, and over the past 50 years or so, CHD has been on the decline. So for men and women, though, over the age of 65, about half of them will still die from a coronary heart disease event. So elevated cholesterol can be elevated for a number of reasons, both from genetic and from lifestyle factors. And treatments for hyperlipidemia include dietary modification, exercise, of course, and the things we're going to talk about today, lipid-lowering medications. Next, let's talk about lipid physiology. If we don't understand the physiology, then we won't understand the mechanism of action of many of these medications. So let's talk about lipoproteins. So the function of lipoprotein particles is to transport lipids around the body in the blood. The lipoprotein particles have hydrophilic or water-loving groups of phospholipids, some cholesterol, and apoproteins directed outward. These characteristics make them soluble in the blood, and things like triglyceride fats and cholesterol esters are carried internally, and they're shielded from the water by the phospholipid monolayer and the apoproteins. Lipoproteins may be classified as follows. They're listed from larger and less dense to smaller and denser, and lipoproteins are larger and less dense if they consist of more fat than proteins. So let's talk about the type of lipoproteins that we find in the human body. So chylomicrons. So they carry triglycerides from the intestines to the liver. They also will move triglycerides around to skeletal muscle and to adipose tissue. Next is very low density lipoproteins, or VLDL. So they carry newly synthesized from the liver triacylglycerol, or another form of triglyceride, from the liver to adipose tissue and to other parts of the peripheral tissues. Now, elevated triglycerides can promote atherosclerosis, but to a lesser degree than LDL. And very high triglycerides can cause pancreatitis, and that's an important test question that you should know. The next is intermediate density lipoproteins, or IDL. And they're intermediate between very low density lipoproteins and low density lipoproteins. So they're not usually detectable in the blood, but they are an intermediate step in some of the metabolism that we'll talk about. Next, low density lipoproteins, LDL. You'll hear about this a lot throughout the lecture. And they carry cholesterol from the liver to cells of the body. LDLs are sometimes referred to as the bad cholesterol lipoprotein. And there's, again, a direct correlation between high LDL and coronary artery disease. And finally, high-density lipoprotein, or HDL. And they're the good cholesterol. They collect cholesterol from the body's tissue and bring them back to the liver. High serum HDL greater than 60 is associated with a lower risk of coronary heart disease. So let's talk about some of the pathways of cholesterol and lipoprotein metabolism. There's two different pathways. One's called the exogenous pathway. So there's intestinal absorption of dietary cholesterol and fatty acids, and they're assembled into what we mentioned before, chylomicrons, and with the help of the apoproteins. And the apoproteins are basically just proteins that bind to lipids to help form the main lipoprotein molecule. So lipoprotein lipase is an enzyme on the endothelial cells of blood vessels, and they hydrolyze chylomicrons, and the chylomicrons will release glycerol and fatty acids that are then absorbed and used in the peripheral tissues. Now these hydrolyzed chylomicrons are now considered chylomicron remnants, and these remnants then subsequently are endocytosed by the liver and then broken down into smaller fat molecules and used subsequently from there. The second pathway is called the endogenous pathway, and this first begins with the synthesis of VLDL, which we talked about before, and this again is in the liver. So glycerol and fatty acids are hydrolyzed by, again, lipoprotein lipase in the blood, and then absorbed by the peripheral tissues like muscle and adipose tissue. VLDL remnants are then referred to as intermediate density lipoproteins, and they circulate throughout the blood as well, and they can further be hydrolyzed by hepatic lipase, and this then produces LDL, or the low density lipoproteins. So LDL circulates throughout the blood and can be absorbed throughout interactions with special LDL receptors, and this becomes an important point later on with some of the medications and diseases that some people will have. These LDL receptors are found in the liver and the peripheral cells, and they're required for LDL to be taken up. So let's talk about cholesterol goals. What do people need to be healthy? What type of goals of cholesterol do we need to strive for? So total cholesterol. So you do a lipid panel on a patient with someone with no major risk factors. They're a healthy individual, and you have no worries for this patient to have any future coronary heart disease at this time. So what do you want their total cholesterol to be? Well, you want it to be less than 200. That's the desirable level for cholesterol with someone with no major risk factors. Now, between 200 and 240, we consider this a borderline situation, and above 240, we consider it high risk. Now, for LDL, which gets a lot of attention with treatment protocols, where do we want that to be? Well, LDL desirable levels are at 130. So 130 and below, you're pretty happy. Between 130 and 160, we consider it borderline, and above 160, we consider it high risk. For HDL, remember HDL is our good cholesterol, and we want that to be as high as possible. So HDL greater than 60 is desirable, between 35 and 60 is borderline, and less than 35 is high risk. And then finally, triglycerides, less than 150 is desirable, between 150 and 199 is considered borderline, and greater than 200 is considered high risk. Now, these were all people who have no risk factors, no discernible disease, and we're not really worried about them. Now, let's talk about people who maybe have some problems, maybe have some risk factors. So one thing you're going to hear a lot about in your practice is ATP 3 guidelines, and ATP stands for Adult Treatment Panel. We use these guidelines in order to risk stratify our patients, decide who needs medication, who doesn't need medication. So patients should undergo a risk assessment to determine their LDL goals. So first off, CHD equivalents, or coronary heart disease equivalents. So these are things that are considered at the same risk level as someone who already has coronary heart disease. And these equivalents mean that in the next 10 years, the risk of coronary heart disease is greater than 20%. So first is diabetes. So anyone with diabetes, it's considered a coronary heart disease equivalent. The others are symptomatic carotid artery disease, peripheral artery disease, and abdominal aortic aneurysm. So any of these four things, we basically classify them as having a coronary heart disease like risk factor. So what are maybe some risk factors but not quite at the level of a CHD equivalent? Well, we call these major CHD risk factors, and they include cigarette smoking, hypertension, so a blood pressure greater than 140/90, or if they're already on antihypertensive medication, a low HDL cholesterol, so if the HDL is less than 40, that's still a high risk factor. A family history of premature CHD, so in males, that means a first-degree relative less than 55 years of age, and in a female, a first-degree relative less than 65 years. And then just age in general. So men greater than 45 years and women greater than 55 years of age are considered to have at least a major CHD risk factor. So we have a chart here, and this is an important chart, and at first it seems a little intimidating, but it really will take a lot of the guesswork out of when do I start a medication, when do I start diet modification on patients. So first we go with a coronary heart disease patient or a CHD risk equivalent. So for that 10-year risk, there's a 20% chance that they're going to have a CHD event. So what do you want your LDL cholesterol to be? So on the chart here, LDL cholesterol goal less than 100. So anyone with a high risk situation, a 10-year risk greater than 20%, you want that LDL goal to be less than 100. So when do we start doing things? Well, let's look at the second part, LDL cholesterol level at which to initiate therapeutic lifestyle changes. So what does that mean? Well, we tell them to exercise, we tell them to improve their diet, decrease their fatty intake, and anything over 100, we want to initiate that. So when do we start medication? So LDL cholesterol level at which we consider drug therapy. Well, greater than about 130 is an absolute indication for initiating that drug therapy. However, it's still optional on whether or not you want to initiate it anything above 100 as well. And I would find most of the time that if you find cardiologists or primary care physicians, they're going to go at that 100 level, and anything over 100 they're going to be treating. So let's move to the next level. So say if a patient has 2 or more risk factors, so they don't have a coronary heart disease equivalent or coronary heart disease, but they have 2 or more of those risk factors that we talked about before. So this means that their 10-year risk is less than 20% for a future event. So what's our ultimate goal? So our LDL goal needs to be less than 130, which is different than the 100 that we just spoke about with the coronary heart disease equivalent. So when do we want to start lifestyle changes? Well, anything above 130, we want to do a lifestyle modification. And when do we want to start medication? Well, there's 2 different answers to this one. So if there's a 10-year risk of 10 to 20%, you're going to want to initiate drug therapy at about 130. So if your LDL is 130 and your risk is between 10% and 20%, you're going to initiate at 130. If it's less than 10%, then you can push that out to about 160. So if your LDL is 160 and your 10-year risk assessment is less than 10%, then you can bounce that all the way up to 160. Now there are equations that you can use to specifically look at the percentage of risk, and you can find those in most books and on the internet today. So let's go for patients with 0 or 1 risk factor. So we talked about our goals for patients who don't have any risk factor, so this sort of encompasses those patients. So we want our LDL cholesterol to be less than 160. Anything above 160, we initiate lifestyle modification. And then for initiating drug therapy, usually once it gets above 190, we absolutely want to start lipid-lowering medication, but there is an optional level between 160 and 190 where, depending on your preferences and all that, you can start medications as well as that. I'll tell you personally, when I see a patient with anything over 160, it makes me nervous, and I strongly encourage diet modification and exercise, and if we don't start to see improvement, then I usually initiate medication at that point. Next, let's talk about some specific classifications of hyperlipidemias. So the first one is type 1, or familial hyperchylomicronemia. And in this disorder, you'll have high triglycerides and an increased risk of coronary heart disease. Now, the main problem is a deficiency of lipoprotein lipase. And in general, treatment is diet alone. Drug therapy is generally ineffective for this disorder. Next is type 2A, and this is familial hypercholesterolemia. And in this problem, you'll have high LDL, but you'll have normal triglycerides. You'll certainly have an increased risk of coronary heart disease. And the major defect here is in the LDL receptor. And without LDL receptors, cells, more specifically the hepatic cells, can't remove LDL from the serum. Next is type 2B, and this is familial combined or mixed hyperlipidemia. And this will entail high triglycerides and LDL. And there's an overproduction of VLDL by the liver, and this is relatively common. Next is type 3, and this is called familial dis-beta lipoproteinemia. And this entails high cholesterol and triglycerides. There's an overproduction or underutilization of IDL, or the intermediate density lipoprotein. And patients will have xanthomas and accelerated vascular disease, and this can develop by middle age. And this will require medication. Type 4, or familial hypertriglyceridemia, and you'll have greatly elevated triglycerides with normal cholesterol and LDL. There's an overproduction and a decreased removal of VLDL and triglycerides in the serum. It's pretty common, and patients are usually obese and have diabetes. Type 5, or familial mixed hypertriglyceridemia, you'll have greatly elevated triglycerides again, but you'll also have elevated cholesterol, but a normal LDL. And again, this is increased production or decreased clearance of the VLDL and also chylomicrons. And this is, again, common in obese patients and in diabetics. Next, let's talk about dietary management of hyperlipidemia. You always want to start with dietary changes. In the U.S., we supersize everything, and it's incredibly difficult to get people to change their eating habits. But that's the first thing we try with anyone with hyperlipidemia problems. So first, you should know that sucrose and fructose raise VLDL. So that will subsequently probably increase your triglycerides and your overall cholesterol patterns. Alcohol can also increase triglycerides significantly. So total calories from fat should normally run around 20 to 25% of your daily food intake. And about less than 8% of this should be saturated fat. And overall, people should not be eating any more than about 200 milligrams of cholesterol a day. Now, patients with a familial hypercholesterolemia or familial combined hyperlipidemia will always require drug therapy. You can put them on the strictest of diets and it still won't work. Also of note, LDL and VLDL may drop significantly during active weight loss. So you want to check LDL after weight loss is stabilized for about a month. Otherwise, you might get some incorrectly low LDLs for these patients. So let's finally get to the meat of it, lipid-lowering agents. So the first one, HMG-CoA reductase inhibitors, or statins. So what does the HMG-CoA stand for? So it's 3-hydroxy-3-methyl-glutaril coenzyme A reductase inhibitors. No wonder we call them statins, because that's a mouthful. So what does that include? So that includes lovastatin, simvastatin, pravastatin, fluvastatin, atorvastatin, and rosuvastatin. So rosuvastatin is the most potent. So it lowers LDL more than any other medication that we have, and it can lower it up to about 60%. It can mildly reduce triglycerides and slightly increase HDL, which is also beneficial. But it also has some other beneficial effects that might be just as effective in preventing CHD as the decrease in the LDL in and of itself. So it can stabilize plaques, it can improve coronary endothelial function. There seems to be an inhibition of platelet thrombus formation, and there's an anti-inflammation activity that could be one of the most important factors in decreasing MIs, myocardial infarctions. Let's talk about the mechanism of action next. So how do these drugs work? Well, they inhibit HMG-CoA reductase, and this is the rate-limiting step in cholesterol synthesis in the liver. So the lower intracellular cholesterol will stimulate the synthesis of LDL receptors. And with this increased number of LDL receptors, it'll promote increased uptake of LDL from the blood. So let's talk about clinical uses. Well, we use it for high cholesterol, obviously, and we've already talked about many of the disease states that promote this. So hyperlipidemia is its primary use. Now, there are some problems. People with familial hypercholesterolemia, the homozygous form, they lack LDL receptors, and the benefit is much less. Now, we still use these medications in these patients, but remember, if you're not having the increase in LDL receptors in the hepatocyte, you're not going to be removing as much LDL from the serum. So we use this in diabetics. So the target LDL for a diabetic is below 100. For coronary artery disease, most of the time, cardiologists are trying to get LDL below 70. Pharmacokinetics, these are all taken orally and they're well absorbed. Their primary action is on the liver, which we've mentioned before, and excretion is through the bile and the feces. Next is adverse effects. So one of the major problems is with the liver. It can cause elevation of serum aminotransferases, and this can be up to 3 times normal. It can be intermittent and not associated with severe hepatic toxicity, but it can be more severe with people who drink a lot of alcohol or alcoholics and people with underlying liver diseases. You do want to check LFTs or liver function tests at the baseline before you give the medication, about 1 to 2 months after you initiate the medication, and then about every 6 to 12 months afterward. The other major side effect is with muscle, so you can get myopathies and more importantly rhabdomyolysis, though the rhabdo is relatively rare. So you can get mild increases in creatinine kinase or CK, and this occurs more frequently but not necessarily clinically significant. You do want to check the CK or creatinine kinase in patients complaining of muscle pain or fatigue. More severe episodes can occur when it's combined with fibrates or niacin. We'll talk about those medications here in a minute as well. And then rhabdomyolysis is also an important thing to discover because it can lead to renal impairment and renal failure. So for drug interactions, it may increase warfarin levels, so you want to be careful with concomitant use with that medication. It is contraindicated in pregnancy, lactation, and you don't want to give this to children or teenagers.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Welcome to Stepping Up with me, Richard Sammons. Woo, woo. Step up, you. Hello, my buff buddies. What enzyme is involved in the rate-limiting step of cholesterol synthesis? Here's a hint. It is inhibited by statins. It's HMG-CoA reductase. Statins lower LDL cholesterol by inhibiting this enzyme, which plays a central role in the production of cholesterol in the liver. Now, let's get back to it. I said statin, not static.
All right, let's go over quick review number 1 in your study guide. First question, your patient, a 53-year-old man, has a total cholesterol of 193 with HDL of 38 and triglycerides of 165. What's his LDL? Well, LDL can be measured directly, but more often it's calculated from the other numbers. So the formula for this is total cholesterol is equal to the LDL plus the HDL plus triglycerides divided by 5. So if you plug in all those numbers and do a little algebra, you come up with LDL of 122. Also, I'll mention that when you check a lipid panel or a lipid profile, you should really always do it fasting. Have the patient come in for his blood draw first thing in the morning, nothing to eat or drink for 8 to 12 hours. Foods can definitely affect the cholesterol numbers, especially triglycerides, and you can get falsely elevated triglycerides, and that's going to give you falsely low LDL when it's calculated if they come in non-fasting. So make sure your patients come fasting, make sure they understand that. Next question. A patient being treated for hypercholesterolemia presents after having lost 30 pounds over the last 3 to 4 months. So that's pretty good, and often, as Dr. Lewis said, the first thing you recommend to these patients is diet, exercise, weight loss, because that's going to help to correct their dyslipidemia. So this patient's lost 30 pounds. He'd like to check his cholesterol and see if he can get off of his medication. What should you tell the patient? Well, it's important to check the LDL after the weight loss has been stable for about a month. You can get falsely low LDL during active weight loss. So the patient's lost weight, congratulate them, say, okay, come back in a month when the weight hasn't really fluctuated anymore, and then we'll recheck. Next question. A 47-year-old male with hypertension presents for a general exam and risk assessment. What should his LDL goal be? Well, this patient has 2 major risk factors. First of all, he's a male over 45. And second of all, he has hypertension. It doesn't matter if the blood pressure is controlled or not. He has the diagnosis of hypertension. This is a risk factor. So he has 2 major risk factors, and the goal for LDL in a patient with 2 major risk factors is less than 130. Next question. A 47-year-old female smoker presents for a general exam. What should her LDL goal be? Well, this patient only has 1 major risk factor. She's a smoker. Her age is not a risk factor because in women, the age cutoff is 55 or higher. So for this patient with 1 major risk factor, the goal for LDL is less than 160. That's the same as if she had no risk factors. Next question. A 35-year-old male with normal blood pressure and no history of coronary disease has very well controlled type 2 diabetes. What should his LDL goal be? Well, now this patient has a CHD, a coronary heart disease, risk equivalent. Diabetes is considered just as risky for atherosclerosis as if you had had known coronary disease. Even a patient who's had 3 heart attacks has the same LDL goal as a patient with diabetes, because we know diabetes is a very strong predictor of atherosclerotic disease. So the goal for someone with coronary heart disease equivalence is an LDL less than 100. And there are some experts who are starting to say that even less than 70 would be optimal, although that's not part of the ATP3 guidelines. Next question. What is the hyperlipidemia classification that is found most commonly in obese and diabetic patients? Well, this is type 4 and type 5. Very common. You get the high triglycerides, often associated with high LDL and low HDL. Next question. What are the 2 most common side effects of statins? Now, I want to say statins are very, very safe. You'll have a lot of patients who worry about the side effects because they hear about them. But statins are very safe. But the most common side effects, still relatively rare, but the most common, include elevated serum aminotransferases. So this includes alanine transaminase, which is ALT, or the older name is SGPT, and also aspartate transaminase, which is AST, or the older name for that is SGOT. So sometimes these are called serum aminotransferases, sometimes they're called transaminases. Often they're just abbreviated LFTs for liver function tests. So elevated LFTs is the first most common side effect, and the other one is muscle involvement. This can take several forms. It can be just myopathy, where you get some muscle weakness, maybe some muscle pain or myalgias. You can get frank myositis, where you get inflammation of the muscle, and so that's why you're checking the CK to see if you have some muscle breakdown. And you can also get full-blown rhabdomyolysis in extreme cases, where you get massive muscle breakdown, and the myoglobin can cause renal failure. It can be very dangerous. So you can have any spectrum of muscle involvement, from very mild myalgias and myopathy up to myositis and full-blown rhabdomyolysis. Next question, what are the two mechanisms by which statins decrease LDL cholesterol? Well, obviously statins are the HMG-CoA reductase inhibitors, and HMG-CoA reductase is the rate-limiting step in cholesterol synthesis. But the other mechanism is that statins seem to increase LDL receptors in the liver, and this enables the liver to take up circulating LDL particles. Next question, why are statins less effective in patients with the homozygous form of familial hypercholesterolemia? Remember, these patients lack LDL receptors. Statins are still going to work somewhat by inhibiting HMG-CoA reductase, so the patients aren't going to synthesize as much cholesterol, but statins are less effective than in the general population because these patients can't upregulate LDL receptors. They don't make LDL receptors, and so they're not able to clear the LDL from the serum very effectively. The next question, what are some physical signs of hyperlipidemia? Now, I want to mention these are all rare signs. Most patients have no signs or symptoms, but some of the signs that you might want to be aware of, atheromas, which are plaques in blood vessel walls, xanthomas, which are plaques or nodules composed of lipid-laden histiocytes that are deposited in the skin. So you'll get xanthomas on the elbow or the earlobe or various other places. You can get tendinous xanthomas, which are lipid deposits in the tendons, especially the Achilles tendon is a common site for these. And then corneal arcus, also sometimes called arcus senilis, where you get this whitish deposits around the edge of the cornea that's deposits of lipid. So that's it for quick review number 1. Let's get back to Dr. Lewis.
Next, let's move on to niacin, or nicotinic acid. Now, this is the drug of choice to increase HDL. It can decrease LDL also, though, by 10 to 20%, and it can markedly decrease triglycerides. It reduces lipolysis in adipose tissue, and it's decreasing free fatty acids in the serum. It reduces plasma VLDL by inhibiting the synthesis of fatty acids in the liver as well. And it can decrease the catabolic rate for HDL. Now, it does have some interesting side effects. Now, first one is flushing, or a burning sensation in the skin, and this can be dramatic. I have more patients who fail this therapy than are successful with it, mainly for this side effect. Now, it's mediated by prostaglandin and histamine release, and it can be diminished by taking an aspirin 30 minutes before taking the niacin. Now, you can also get some mild LFT increase in GI disturbance, and the LFT increase can happen more often when combined with a statin medication. Next, let's move on to the fibrates. So the two medications, fenofibrate and gemfibrozil, are the two main ones. Now, these are the drug of choice for decreasing triglycerides. You can also get a mild increase in HDL, but in general, this is the triglyceride drug. So fenofibrate is slightly more potent than the gemfibrozil. And let's talk about a little bit about its mechanism of action. So there's an upregulation of peroxisome proliferation activated receptor, or PPAR. Now, this results in increasing expression of lipoprotein lipase, and this thus increases VLDL clearance. And there's also a decrease in hepatic triglyceride secretion as well. Pharmacokinetics, completely absorbed after oral intake. It's bound to albumin throughout the body, and it's excreted in the urine. Adverse effects, you can get some mild GI effects. What's interesting about the fibrates is that you can get increased lithiasis. So because there's an increased biliary cholesterol excretion, you can get some gallstones. Also, similarly to the statin medications, you can get some muscle breakdown, muscle weakness or fatigue, The rhabdomyolysis is more common when the fibrates are combined with statins. But in general, if they're used alone, you don't see that very often, but you can check your CK levels in any patient who's having muscle pains or fatigue. Again, it's contraindicated in pregnancy. You probably don't want to use this in hepatic or renal dysfunction or anyone with major gallbladder disease. Let's talk a little bit about resistant diabetic patients. I find in my practice that I have a difficult time controlling triglycerides in my diabetic patients. So make sure you get very, very tight control on your sugars in your patients because that will help you with controlling your triglycerides. Next, let's move on to bile acid binding resins. So this is cholestyramine, cholestyramine, and cholesevelam. So these lower LDL. And their mechanism of action is that these are large resins of hydrocarbons, and they can bind bile salts. And bile salts are basically the metabolites of cholesterol. And bile salts are usually reabsorbed in the jejunum or the ileum, but because when they're bound in the large size of these molecules, there's no reabsorption across the intestine. And because the bile salts are not reabsorbed, the liver has to increase conversion of cholesterol to bile salts to replenish the supply of the bile salts. So, and this also will show an upregulation of LDL receptors, which will help remove LDL from the serum as well. Clinical uses, again, hyperlipidemia, so it can reduce LDL by 10 to 20%. It's often used in combination with statins for patients with type 2A or 2B hyperlipidemias. Now, there's a lot of adverse effects, and that's why these medications aren't used routinely. There's a lot of GI effects. There's constipation, nausea, flatulence. Cholesevelam tends to have a little bit fewer side effects, so it's used maybe a little bit more often. You can get impairment of your fat-soluble vitamin absorption, so ADEK, A-D-E-K vitamins have a hard time being absorbed with these medications. There's a lot of drug interactions because you'll have a decreased absorption of many drugs. So tetracyclines, phenobarbital, digoxin, warfarin, pravastatin, aspirin, thiazide diuretics. So if you're going to take these drugs, you need to take them 1 to 2 hours before giving the bile acid binders or 4 to 6 hours after. So you don't want to give them at the same time because they just won't be absorbed. Next, let's move on to cholesterol absorption inhibitors. And really there's just one example, ezetimibe. And this works in the small intestine to reduce cholesterol absorption. It can decrease LDL by 15 to 20%, and it's often combined with a statin. There has been a drug trial that did show a combination of simvastatin and ezetimibe that didn't show much improvement other than just simvastatin alone. So there was a bit of a backlash, and we stopped using that combo quite as much as we used to. But the clinical use is still when patients are intolerant to statins or when they're used in combos when a statin is not getting you to your goals. It doesn't affect the fat-soluble vitamins, so your A, D, E, K vitamins don't have any problems being absorbed when on ezetimibe. Adverse effects, pretty well tolerated, but you can get some fatigue and some diarrhea. Finally, let's talk about the omega-3 fatty acids or fish oil. These are very, very popular right now. They're over the counter, but there are some prescription versions of this as well. And how do they work? Well, they activate the PPAR like the fibrates, and their primary improvement is in triglycerides. Also, and this is maybe a little off-label, there are some anti-inflammatory properties. Some people are using this for asthma and osteoarthritis and other pain syndromes as well. The prescription version is 4 grams a day divided BID. You have to be careful. Patients think they're taking enough fish oil on their own as an over-the-counter, but in general they're only taking 500 milligrams or even 1,000. And you really have to bump up the dosage on these. And unfortunately, by the time you bump it up to 4 to 6 to 8 grams a day, the side effect of the fishy burp starts to show its head. So it's hard to get that on the over-the-counter. The prescription version tends to be a bit better tolerated. And that's the end of our lecture today. Thank you for paying attention. You can go back to eating your pork rinds if you so desire. This has been our anti-hyperlipidemia lecture, and I'll see you next time.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Oh no, it's...
That's right. I'm coronary heart disease. the leading cause of death in the United States.
But haven't you been on a steady decline since the 1960s due to advances in drugs for hyperlipidemia?
You silly human. I still kill 50% of people over the age of 65. My risk factors include smoking, hypertension, low HDL, and family history of premature CHD and age over 45.
No! What can I do? I know I will take a statin to decrease LDL, improve coronary endothelial function, inhibit platelet thrombus formation, and for its anti-inflammatory properties.
Dude, it was horrible acting. Gosh, you're not even trying.
It doesn't matter if my acting sucked, as long as we retain the information.
I am stomping and roaring my butt off over here to get ready for this exam, and you don't even care. You know what? I can't take this. I'm going in my trailer.
Well, someone's a diva.
Okay, let's look at quick review number 2 in your study guide. The first question, what causes the flushing side effect of niacin? Well, this is due to prostaglandin release and histamine release. Next question, what is the mechanism of action of the fibrates? Fibrates cause upregulation of peroxisome proliferator activator receptors, or the PPAR or PPAR receptors, and this results in increased lipoprotein lipase activity and increased clearance of VLDL. Next question, rhabdomyolysis is more common when fibrates are combined with what other medication? So fibrates can cause rhabdomyolysis by themselves, but so can statins. So if you combine a fibrate and a statin, you have a much higher incidence of rhabdomyolysis. So you have to use extreme caution if you attempt to use these drugs together. And often, as we've mentioned, it's very common for a patient to have both elevated triglycerides, so you might want to reach for a fibrate, and they also have elevated LDL, so you want to reach for a statin. But you have to be aware that if you combine those two, you're going to have a much higher incidence of rhabdomyolysis. A lot of physicians don't feel comfortable using that combination at all. It's just too high risk. Next question. A 55-year-old male with hypertension has an LDL of 92, an HDL of 20, and triglycerides of 150. What lipid-lowering medication would be most appropriate for this patient? Well, first of all, what's our goal of therapy? Well, the LDL looks okay, and the triglycerides look okay, but the HDL is low. So what's the drug of choice to raise HDL? Niacin. Next question, what are the two mechanisms by which bile acid binding resins decrease cholesterol? Well, these drugs are going to deplete bile salts and force the liver to convert cholesterol to bile salts. You need bile salts, so your liver is going to have to take cholesterol out of storage and convert that into the bile salts because your body's not able to reabsorb the bile salts. These resins also lead to upregulation of LDL receptors, which will remove LDL from the serum. The drugs don't directly cause this, but because the body needs to take cholesterol and turn them into bile salts, the body will upregulate the LDL receptors in the liver, and so you do get increased uptake of LDL from the serum. Next question, which lipid-lowering medication works in the intestine but does not affect the absorption of fat-soluble vitamins? This drug is ezetimibe. Next question, if a patient wanted to take an over-the-counter medication to decrease triglycerides, what could you suggest? Well, you might reach for an omega-3 fatty acid, and these can be available over the counter, and they're also prescription omega-3 fatty acids. These are the fish oil pills. Next question, what would be an appropriate scenario to use ezetimibe? Well, if you had a patient with elevated LDL who can't tolerate statins, you need something to get the LDL down, and ezetimibe will do a good job of that. It's not as potent as the statins, but it definitely does lower LDL pretty well. Next question, a 60-year-old female smoker has an LDL of 90, an HDL of 50, and triglyceride level of 350. What lipid-lowering drug would be most appropriate? Again, what's the problem we're looking at? LDL's good, HDL's good, triglycerides are elevated. So what's the drug of choice for lowering triglycerides? A fibrate. So that's it for quick review number 2. Now's a good time to pause the video and complete the end of session quiz. Then restart the video and we'll go through the quiz together. All right, let's look at your end of session quiz. The first question, match the side effect to the drug class with which it's most commonly associated. So rhabdomyolysis is associated with two classes. We talked about these, the HMG-CoA reductase inhibitors, or the statins, and then the fibrates. Which drug most commonly causes flushing? This is niacin, very common side effect from niacin. Which drug most commonly causes lithiasis? These are the fibrates. They're going to lead to cholelithiasis, or gallstones. And which drug class leads to impaired GI absorption? These are the bile acid binding resins. Next question, match the drug with its primary effect on lipids. First drug is simvastatin. It's a statin drug. It's going to lower LDL. The next drug is gemfibrozil. Gemfibrozil is a fibrate. It's going to lower triglycerides. Niacin, as we said, is the drug of choice to raise HDL. And ezetimibe will lower LDL as its primary effect. Next question, true or false? Ezetimibe inhibits the absorption of fat-soluble vitamins. Well, again, this is false. Ezetimibe does not block the absorption of fat-soluble vitamins. The bile acid binding resins inhibit the absorption of fat-soluble vitamins, so you need to be aware of that. Next question, name the major CHD risk factors that can alter your LDL goals of the ATP3 guidelines. So we're not talking about the CHD risk equivalents. We're talking about CHD risk factors, major risk factors. These include cigarette smoking, hypertension, low HDL, family history of coronary disease, and age. And again, we talked about the different age cutoffs for men and women. For men, if you're over 45, that's going to be considered a major risk factor. For women, the age cutoff is 55. Next question. Homozygous familial hypercholesterolemia patients lack which type of receptor, and why is this clinically significant? Well, these patients lack LDL receptors, and so they're not going to benefit as much from statins, which will upregulate those LDL receptors in other patients. Next question. How often should the serum aminotransferases, or the LFTs, be checked in a patient taking a statin drug? Well, you're going to check at baseline to make sure they don't have any liver disease before you start the drug. You're going to check again after they've been on the drug for 1 or 2 months and make sure you don't have much elevation. And then you're going to check somewhere about every 6 to 12 months. If the patient comes in at 2 months and their LFTs are just a little bit elevated, you might check again after 2 more months, again after 2 more months, and make sure that they're not continuing to rise. And the cutoff for when you need to stop your statin is when those LFTs get to 3 times the upper limit of normal. Next question. Very elevated triglycerides can lead to what potentially serious problem? Well, this is pancreatitis. Remember, pancreatitis can cause multi-organ failure. It can cause death. It can be a very, very serious disease. And so elevated triglycerides are one of the things on the differential of causing pancreatitis. Next question. In order to decrease the flushing effect from taking niacin, patients can take what? So one thing these patients can take is aspirin. If they take an aspirin, even a small dose of aspirin, 81 milligram aspirin or a baby aspirin, if they take that baby aspirin 30 minutes before they take the niacin, that will reduce the incidence of flushing. You can also tell the patient to take the niacin at bedtime. The idea is they may still flush, but if they're flushing while they're sleeping, they may not be aware of it. Now, if they wake up from the flushing, that's no good. But sometimes you can just tell the patient, look, take your baby aspirin 30 minutes before bedtime, and then take your niacin right at bedtime, and you'll never notice any flushing. A couple of other things worth mentioning. You can tell patients not to drink alcohol at night because that can increase flushing. You can tell them not to drink hot beverages at night. Some patients like to drink a cup of coffee in the evening, and that will increase flushing. So tell them to avoid hot beverages and alcohol. And then finally, tell them to be persistent. If they stick with the niacin, that flushing will generally get better or more tolerable over time. So if they come in and they say, look, I took this 3 days and I'm flushing, I just can't stand it, tell them, look, stick with it for a couple of weeks, maybe a month, and that flushing may become more tolerable. Next question, what are the 3 mechanisms by which statins lower LDL cholesterol? Well, first of all, statins inhibit HMG-CoA reductase, and so that's going to lead to decreased cholesterol synthesis. Now, because you're not making as much cholesterol in the hepatocytes, you have lower intracellular cholesterol, and that stimulates an increase in the LDL receptors on the cell, so you can take up more LDL from the serum. And then finally, that lower intracellular cholesterol also decreases the secretion of VLDL into the serum. And the last question, omega-3 fatty acids primarily affect what type of cholesterol? Omega-3 fatty acids will primarily affect your triglycerides. So that's the end of the end of session quiz, and that's the end of this session on hyperlipidemic drugs.